First of all, good morning to everybody, and thank you very much for devoting time out of your busy schedules and that too on a weekend to discuss the science behind the current cell and gene therapy in multiple myeloma. And I would like to thank Dr. Agarwal sir again for giving us this opportunity and providing a space for all the big brains in hemato-oncology to assemble at one single space. I'm from the Dr. Reddy's medical oncology and hematology team, and I take this opportunity to inform the team that we at Dr. Reddy's have always been at the forefront of providing cost-effective and innovative therapies in hemato-oncology. We did it with the introduction of the first biosimilar rituximab, then with the first GCSF analog. And looking at the current unmet needs in multiple myeloma, we will be bringing the first CAR T cell therapy for myeloma, hopefully by September 2025. And it will be the second myeloma CAR T cell therapy worldwide to be based on a nanobody structure. So, of course, there'll be much more updates here by Dr. Vikram Mathew sir and Padmaja ma'am. Over to you, Dr. Mohan Agarwal sir, and thank you so much for providing a space for discussion here among all the esteemed members present.
Thank you, Dr. Pranay. Good morning to one and all. Today, our guest speaker are Dr. Vikram Mathews from Vellore and Dr. Padmaja Loki Reddy from Hyderabad. Both of them will be speaking on CAR T therapy for myeloma, including their own experiences from India. This webinar is brought to you by Mumbai Hematology Group. It is supported by Dr. Reddy's and managed by Perfect Square. I thank Mr. Ashok VK, Dr. Pranay Sopori, Mr. Tarun Pratap Singh from Dr. Reddy's, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our chief guest today, Dr. Rajat Bhattacharya from Kolkata, both the guest speakers, Dr. Vikram and Dr. Padmaja, all our discussants who are themselves eminent hematologists, hemato-oncologists, you participants for sparing your Sunday morning. Next weekend, Saturday, at 7 p.m. IST, we have Dr. Meera Mohan from Milwaukee speaking to us on risk stratification of myeloma in 2024. And next Sunday morning, that is 28th July, 11:30 a.m., we have Dr. Samir Melinkari from Pune speaking to us on bispecific antibodies in hemato-oncology with Indian experience. We have a good number of discussants today. The time will not allow me to introduce them properly, but I'll just tell you who they are. So we have Colonel Dr. Ashok Meshram from Kolkata, Dr. Abhishek Shankar from Delhi, Dr. Aditi Shah Kaska from Mumbai, Dr. Amit Khurana from Surat, Dr. Anupama Jagya from London, Dr. Ashish Dikshit from Bangalore, Dr. Bilal Kaji now from Mumbai, Dr. Chirag Shah from Ahmedabad, Dr. Hamza Dalal from Mumbai, Group Captain Dr. Harshit Khurana from Pune, Dr. Himal Shah from Ahmedabad, Dr. Jeevan Kumar Garg from Kolkata, Dr. Mr. Karan Gera from Immunoadaptive Cell Therapy, Mumbai, Dr. Kartik Kumar from Rishikesh, Dr. Khushbu Jain from Aurangabad, Dr. Kunal Chattani from Nagpur, Colonel Dr. Kundan Mishra from Lucknow, Dr. Lakshmi Nath from Kochi, Dr. Mayan Singh from Delhi, Dr. Monisha from Kochi, Dr. Nilesh Jain from Raipur, Dr. Nilesh Dhakate from Nagpur, Professor Dr. Colonel Prakash Chitalkar from Indore, Dr. Prakash Singh Shekhawat from Jaipur, Dr. Priyanka Samal from Bhubaneswar, Dr. Punit Jain from Navi Mumbai, Dr. Prasanna from Tiruchirappalli, Tamil Nadu, Dr. Rahul Arora from Nagpur, Dr. Rahul Purwar, once again from ImmunoAct Mumbai, Dr. Roshni Pandey from Jabalpur, Dr. Srivastava from Shelby Hospital, Indore, Dr. Sachin Bansal from AIIMS Bhopal, Dr. Sadhana Sharma from AIIMS Patna, Dr. Sekar Datta from Bhopal, Brigadier Dr. Sanjeevan Sharma from Leh Ladakh, Dr. Sanket Shah from Ahmedabad, Dr. Satish Kumar from Bangalore, Dr. S.P. Verma from Lucknow, Dr. Sanyal from Mumbai, Dr. Sudhir Kumar Atri from Rohtak, Haryana, Dr. Sundar Shivale from Kolkata, Dr. Tejaswini Gudibande from Shivamoga, Dr. Vipul Sheth from Delhi, Dr. Vishwadeep Kushru from Nagpur. It's my pleasure to introduce both the speakers of the day. They don't need any sort of introduction because 90% of the audience know them, but we do have people who have logged in from outside India. And for everybody, and to complete the formalities, a couple of lines to introduce them. So we have Dr. Vikram Matthews, who is Director, CMC, Vellore. He did his MD Medicine from CMC Vellore in 1996. This was followed by DM in Clinical Hematology from CMC Vellore 2001. Subsequently, he was postdoctoral fellow in the Stem Cell Biology section, Department of Internal Medicine, Washington University, St. Louis, US, from June 2003 onwards. He was bone marrow transplant fellow in the BMT unit of Washington University, St. Louis, from May 2004. Currently, as it was stated, he is Professor, Department of Hematology at CMC Vellore and also Director of the Institute. He received Welcome DBT India Alliance Senior Fellowship in 2012 and 2018. He was Welcome DBT India Alliance Team Science Grant Principal Investigator in 2024. His areas of academic interest include myeloid malignancies, allogeneic transplant, cell and gene therapies. Dr. Padmaja Lokireddy from Apollo Hospital, Hyderabad. She is clinical hematologist, hemato-oncologist, and bone marrow transplant specialist at Apollo Hospital, Jubilee Hills, Hyderabad. She also sees outpatients as on-call basis at Avasa Hospital, Manikonda, Hyderabad. She completed her MBBS from Devraj Ars Medical College, Kolar, in 1998, DNB General Medicine from Manipal University 2003, and MRCP UK from Royal College of Physicians, London, UK in 2008, FRC Path Hematology from Royal College of Pathology, UK, and has been on specialist register with General Medical Council, UK, to practice specialty as independent consultant in UK. Before returning back to India in 2015, she spent time in Johns Hopkins Cancer Hospital, USA, and worked as bone marrow transplant consultant at Queen Elizabeth University Hospital, Glasgow, University Hospital, Birmingham, UK, consultant hematologist at Eastwick Hospital, part of Cambridge, and University Hospital, Leicester, UK. Before they speak, we have our special guest who is going to inaugurate the webinar today. And that's none other than Dr. Rajat Bhattacharya, now from Kolkata. He is MBBS, MD Pediatrics, DCH, FRCP-CH, FRC Path CCT in Hematology UK, Senior Consultant Pediatric Hematology, Oncology and Bone Marrow Transplant at Apollo Multi-Specialty Hospital, Kolkata. He did his undergraduate medical training and postgraduate pediatric training, that is MD Pediatrics, from the Medical College, Kolkata. He pursued further pediatric and hematology training in UK 1998 to 2010. He completed specialist registrar training CCT in hematology UK and passed the FRC Path exam. He also did 1-year fellowship in pediatric hematology oncology from Vancouver Children's Hospital, Canada. He was a senior consultant in KK Women and Children Hospital, Singapore for 10 years, that is 2013 to 2023, before relocating back to Kolkata. He has been trained in managing all pediatric hematological disorders. However, his special interest is in malignant hematological conditions, including pediatric leukemia, lymphoma, stem cell transplantation, especially haploidentical transplant and cellular therapies. He started the haploidentical stem cell transplant program in UK Women and Children's Hospital, Singapore in 2014, which has shown a very rapid evolution of technique due to the use of selective T cell depletion and the use of haploidentical donor. He has introduced the same technique in Apollo Hospital, Kolkata, and helped in establishing the CAR-T therapy program as well. We are very, very fortunate to have him today to inaugurate our webinar and give some words of wisdom. So over to you, Rajat. I'll just stop sharing.
Thank you, sir. Good morning to everybody. It's actually a great honor for me to be inaugurating the webinar. So I thought in 3 minutes, I will tell my life experience and what the new hematologists, budding hematologists should think about themselves in future. So when I was a child, I wanted to be a pediatric cardiologist because I had a family relative who used to come from US and who was a pediatric cardiologist. But then, so that was the goal. But then when I was doing my MD in pediatrics, I did a thesis on leukemia in children, and the results were abysmal. So that made me think that maybe I go to abroad and learn how to treat these children with leukemia. So I went to UK, and then I ended up in Bristol Children's Hospital with a transplant unit, and suddenly I was exposed to very high-level transplant. This is 2002 as a fellow. I was seeing haplotransplants, double cords, a bit much unrelated. So then goalposts shifted a little bit towards doing transplants. But at the same time, the UK, what I think was important to learn was to put patients first and be compassionate, the empathy, sympathy they show. That's something British really do very well. So then I thought North America may be something I should go for a year, and I cannot tell you how important that was. So the fearlessness they have, the taking risk, and not so much worrying about the evidence base, the extra steps they take. So then the goalposts shifted, and the goalposts. I came back to India with the hope to do some transplant, some leukemia care. But it didn't work, so I was in Singapore for 10 years. And that taught me that if you have unlimited resources, you really can break the boundaries. And my goodness, the sort of children I was able to save there with unlimited resources and taking risks, that was unimaginable. So the goal still remained to come back and work in India, although it's like 24 years later. But when I come back last year, I see a different India. The sort of stuff I was doing in Singapore, I can do part of it. So I started the alpha beta 45RA haplotransfusion thalassemia, and with the help of Rahul and Immunet, we are going to start on the CAR-T. So, and the type of activities happening in cell and gene therapy is huge in India. So I think the future is bright. For the budding hematologists, I will say a few things. First is just have put patients' interest first. Show them empathy and care, and every day we take decisions. But as long as you take with the patient's interest, best interest in your heart, even if it goes wrong, you'll be able to live with it. And second will be to take calculated risk. You have to push your boundaries, go beyond your comfort zone. And that's how we are going to innovate and get better at what you're doing. Third thing, I'll say collaboration. Make friends. So the two speakers today, Dr. Vikram Matthews, I didn't know him, but I just used to email him for my complicated thalassemia patients from Singapore, and he would answer and guide me. Second is Padmaja. I didn't know her, but through a common friend we met, and then I know what she's good at, and so I'll call her for opinion and things. So this is very important in future to come. And I would say sky is not the limit for you guys. The way things are developing, I take a quote from the cinema Gully Boy, that apna time aayega. I think India is developing the way it is developing, infrastructure and the low cost model, what Rahul Pura has brought in. I think that's going to be our USP. And as a hematologist, just you guys are at a time, look forward to a very, very bright future in your life, and be innovative, bring the low cost, and bring the patients from the West to India for treatment. That's what I would want to see. So with that, I start the webinar, and thank you very much, sir, again for the opportunity.
Thank you, Rajat, for those wonderful words, encouraging. And I'm sure a lot of students and others who are listening to you this morning will be excited to take up this branch of medicine as their career. 2 days ago, courtesy ImmunoAct, the team Some of them are present over here today. We had an exposure to CAR-T in India for 4 hours. And today is probably an extension of the same. So I invite our first speaker, Dr. Vikram, to give his talk.
Thank you, sir. Can you see my slides and can you hear me clearly, sir?
Yeah, we can see your slide, just the slideshow mode. Yeah.
Okay, okay.
Wonderful.
Okay, good morning, everybody. And Dr. Rajat, nice to have met you before. Nice to see you on the Zoom and hope to meet up in the near future as well. So today morning, thank you, Dr. Agrawal, for inviting me to give this talk. Can't say I'm an expert in this area, but I will tell you a little bit about our experience. Over the next half an hour, 35 minutes, we'll talk a little bit about CAR T cell constructs and targets in myeloma, talk a little bit about improving access to CAR T cells, summary of the current data, the context of myeloma, and I'm not going to wade through tons of data, just going to give the highlights and the key areas that most of you all are kind of familiar with this literature. The challenges and opportunities, as Dr. Rajat has already pointed out in the context of India. I'll talk about a case and then a little bit about toxicity, again, not into great detail, but just some practical experiences that we've had in managing some of these patients. Between Dr. Padmaja and me, we decided that I will give an overview and talk a little bit about a case that we treated, but Padmaja will give the overview of the data from India. And thank you, Dr. Padmaja, for working with me to take me through this talk. Many of you all, this is a focus group and don't really need this kind of an introduction, but I'm assuming that there must be some students in this audience, and therefore we will just walk through a little bit of CAR T cells, the concepts, the very basics. For those who are familiar, please do bear with me. So if you look at the immune system, broadly, we all recognize there's a humoral immune system and that there is the cellular immune system. Now, we all know that the humoral immune system is very specific. It can really lock into a particular antigen, but it is not as efficacious as the T cell system. But the T cell system is more complicated. It has to engage, it's MHC restricted, then it has to develop some kind of a response to that, and there's a selection. That's a long time in terms of getting a response, but when it does become active and recognized through the T cell receptor with the appropriate MHC, the efficiency with which it can kill is really impressive. And a CAR T cell now brings both these elements together. It basically takes the variable light and the variable heavy chain, puts it into a single chain in a construct, links it to the T cell receptor and the CD3 activating domain and the co-stimulatory domains. This is all intracellularly. And the way that is done is basically you have a lentivirus, which is gutted, so it cannot have any replication by itself. And into that, you put in the nucleotide sequences of the variable light and the variable heavy chain, try to maintain the color codes over here, the transmembrane domain, the immuno co-stimulatory domain, the CD3 zeta domain. And this entire thing is called the vector, and how this is constructed, every single element of this, including the distance in the linker or the spacer, the distance between the transmembrane construct, and the number of nucleotides and distances, small changes can have huge impact in terms of efficacy and toxicity. So this construct that is in a lentiviral, in a gutted lentivirus is called the vector that is now inserted into a T cell. And there are different mechanisms. We won't go into it, how it is done. Most of the time, lentivirals will infect directly. That lentiviral gets into the nucleus. It actually integrates with the DNA and then produces mRNA and the protein. The protein will automatically go to the surface and take the structure that the sequence that you have put in is over there. This now recognizes a very specific antigen that this original antibody from which it came from was going to recognize, CD19 in the case of ALL and lymphoma, as we all know, and that brings about its kill. Now, there are these generations of CAR T cells. Again, most of it are familiar with it. You have the single chain fragment variable, the heavy and the light. And the early days did not have a co-stimulatory. Then the second generation had the co-stimulatory domain with the CD3 zeta. And the third generation has two co-stimulatories, and then the fourth generation, and there is constant evolution of this with additional strategies to make it more targeted, more efficacious, less senescence, etc., which we won't go through today. But what we'll go through today is just to highlight to you the concept of nanobodies. While most species have an antibody like what I showed you earlier, you have a constant region and then you have a variable region, which is the actual end portion of this, which actually recognizes your epitope. And from that is where you get your single chain fragment variable, usually the VH and the VL together, that is then linked to the rest of the T cell aspects to bring about a CAR T cell vector. In certain species, the Camellidia species, for example, that's most of the camel-looking organisms, llama from South America, probably most of the camels as well, and sharks. I'm not sure how these two got together. But their antibody structure is different. They don't have the variable chain. They have only they don't have the variable heavy and light chain. They have only the H, the variable H. And this component, when it's taken out alone, is called a nanobody. So this variable head, so now the consistent figure that you all have seen in the past with the generation, you can also add one more where you have a single domain, just the VHH part, which is called the nanobody. And there are many significant advantages of using nanobodies. So it will look exactly like this, but only thing is you won't have a spacer and a linker, though you could have two VH domains which are linked through a linker. But many of them are actually a single nanobody against BCMA, for example. And then there's a transmembrane domain, and the rest of it essentially remains the same. So if you look at the 6 FDA-approved CAR T cell vectors that are out there, most of them, as you know, are directed against CD19, and we have 2 directed against BCMA. All of them have the single chain fragment variable structure. That is the classical structure that all of us are more or less familiar with. But cilta-capigen autoleucel is different. And the way it is different is, instead of that single chain fragment variable with the heavy and the light, it uses 2 nanobodies which identify, they are basically derived from, I think it's from the llama. So there are 2 nanobodies which are linked together, and they recognize overlapping epitopes of BCMA. So in a sense, this is a nanobody structure with 2 nanobodies which have been brought together, which recognize overlapping antigens on BCMA, along with the rest of it. So this is a list of some of the advantages and or comparison rather than advantages, disadvantages. I think while you'll read the table, I will just point out what is generally considered the most important aspect of the advantage of the nanobody. One, it is believed to have lower immunogenicity. While many of the constructs have a single chain fragment variable from mice, many of them are humanized. So for example, the ImmunoAct 1 is also a humanized CAR T vector. But in the case of the nanobody, it is believed that the VH construct by itself is actually very low immunogenicity. And in addition to that, to humanize it is much easier. It is also believed to be easier to work with. It has greater binding. And apparently, the data would suggest that there is less risk of CRS toxicity. That remains to be seen in larger studies. The transduction efficiency and the overall creation of the construct is also believed to be easier. Now, keeping that in mind, whenever we talk of CAR T cells broadly in all malignancies, more so in solid tumors, CD19 is an exception where CD19 is only expressed on lymphomas and ALL and on normal B cells. And if we lose normal B cells, we can live with it. But most other antigens on cancers are very difficult to find that is unique to that cancer. So they're often expressed on other tissues, and therefore you could have cross-reactivity, which could be fatal, or you could have significant side effects. So the strategy has been always to try and look for antigens on the surface of cancer cells that are unique, or at least largely unique to the cancer. And even when it is not unique, nowadays there are strategies to try and address that as well, which I won't go into detail. But coming to myeloma, while we know of BCMA being targeted by cellular therapy, there are a number of potential antigens. Not all of them are targetable because many of them are expressed by a number of tissues. And there's also, whenever we have BCMA, you could imagine that sooner or later you will have resistance to BCMA-based CAR T cells. So there's a lot of work going on to produce additional CAR T cell or immune therapies or bispecifics, which are targeting different agents, different targets. And there are already clinical trials going on that are targeting various agents that are shown over here. The objective is not to go through each of them, just to tell you there are different strategies that are being pursued to target common pathways, to target molecules that are fairly unique to plasma cells, or at least enriched in plasma cells. And then even interesting concepts like CD19 positive myeloma cells are thought to be more immature and represent a myeloma stem cell population. So there's a potential possibility of a dual CAR or having a CAR that directed against, for example, BCMA and CD19. Not been done, but these are concepts that are considered to be potentially evaluate or evaluable in the future. And there are various other strategies to try and make the antigen of interest on the surface. Even with BCMA, there is data to suggest that prior therapy with even drugs like Atra can increase the expression of BCMA on the surface before actually putting in your CAR T cells. So there are various strategies that are being evaluated. Now, we all know the success of CAR T cells, how, I mean, this is a picture that all of you all are familiar with, how this child with relapsed refractory ALL was cured, and every year she takes a picture. Really a beautiful story. But what is sad is this therapy, which is a very powerful therapy, doesn't cure everybody, but a high chance of cure, is not accessible to the vast majority. So how do we improve access and constraints and challenges that we have? I'm going to deviate a little bit, but I'd like to tell you where we are in the country. So what you generally want to do when you want to improve access within your own country is to increase research capacity, local manufacture of reagents, local manufacture of vectors, point of care manufacturing, I believe, also has a role, public and government and private partnerships. And we in India are actually in a very exciting phase because almost all of this is actually in place. Rahul Purwar is on the top, really a pioneer, and his work with IIT Mumbai and TMH, Dr. Hashmukh, Manju, and Gaurav Narula and his team has really been inspiring. And they have actually taken to market, which is not a mean feat. It's really something to be proud about. It's a humanized indigenous CAR T cell, and it is currently being marketed in the country. So that's a long route, and that's been achieved. There are others also in the field. Immunil has just got market approval as well. There are other organizations, and Origin is working on a CAR T cell program, and you'll get some data on their myeloma CAR T. There are also good government-public partnerships that are going on. The one thing that is really lacking for us is local manufacture of reagents. Now, when you talk about CAR T cells, it's not just a vector. There's a lot of reagents, disposable consumables, apheresis machines, constructs, culture media, cytokines. Every one of them is imported. And if our manufacturing teams, and these are not really, the things that we manufacture in this country are far more complicated than what is required over here. But if industry steps into this place, the cost of these products could really, really, really decrease. When you talk of CAR T cell manufacture, for the most part, we have a centralized industrial manufacturing kind of a concept where cells are shipped to a central patient, manufactured, and then shipped back to the hospital. Fair amount of logistic challenges. Also, getting your patient who is sick, ready, and timely, then there's weeks apart before the cryopreserved product has its own challenges. The alternative is point of care manufacture, where everything comes to the center and the CAR T cell is actually manufactured just before the patient actually needs it. You have a fresh in, fresh out product, and you can infuse it directly to the patient. So just an illustration of how a fully automated Clinimax system will look, housed in a fairly clean room. That's about all. And this is basically Marcus D. Lima at Case Western, where they did some of the early trials. We've actually standardized this. We finished our phase 1 trial with this, and we are waiting approval for our phase 2 and market approval trials as well. We do it in a class 10,000 facility with the Clinimax Prodigy system. While everything is a closed system, there can't be an open system in this, but it's really a fully automated closed system, and I won't take you through the details, but basically once you prep and set up the machine with all the reagents, the entire system is automated and it walks you through, and at the end of 9 to 12 days, you have a product that's ready to be infused. With regards to myeloma CAR T cell, talk a little bit about the data. To date, there are 2 anti-BCMA CAR T cell products that are available. Again, I'm sure most of you all are aware of this. Captogen Viclucil, Idacil, that was the first one to be approved, I think, in 2020. It's also called Abecma. It's also called BB2121 because sometimes these things are given in combination with others, and it's important to remember that the original one was BB2121. Then there's Cilta-Captogen Autoleucel, which I talked to you a little bit about earlier. And this is slightly different in the sense that it works on the nanobody technology. Both of these are currently approved by FDA for relapsed or refractory myeloma after greater than 4 prior lines of therapy. Let's look at the Captogen Viclucil data. Again, the objective is not to walk through the entire inclusion-exclusion criteria and all the baseline data. You can easily access this data. It's really available online. I'm sure many of you all are already familiar with it. But the take-home points are about 128 patients. Out of 148, 128 actually received the product. The cell dose was slightly different. They didn't use a per kilogram. They used a 150 to 450 million CAR T cells. The overall response was 73% in a heavily pretreated group of patients. 42, that's 33% achieved a CR, and of that 33, 79% were MRD negative. Of the total population that went into this cohort that went into the study, 26% achieved MRD negative. The progression-free survival was not that impressive. I mean, in a heavily treated group, it's not bad, 8.8 months with a 95% confidence of 5.6 to 11.3 months. And the overall survival at 12 months was 78%. Grade 3-4 hematotoxicity was 91%. CRS was seen in 84. Majority of them, which is grade 1-2, which is not difficult to handle. Grade 3-4 was in a very small proportion of patients. Neurological toxicity was seen in 23. For the most part, it was mild. 14 patients died. They go on in this manuscript to talk about a dose response effect without getting into the details. Basically, what they showed was the best response they got was with the 450 million cells when that was infused. They had an overall response of 81. Did not really translate to an improvement in either progression-free survival, time to event, or overall survival. But the response rates itself were better at the higher cell dose. And obviously, as goes with many of these malignancies, the CR and stringent CR had a better survival than those that did not respond. And that's the overall survival curve, again, at a fairly short follow-up. Moving to the Cilta-cel data, there's the Cartitude one. There were 2 publications. The first came out in Lancet in 2021. And there was a follow-up of this, a longer follow-up, 2-year follow-up of the same data, which was published in JCO 2 years later. Again, the summary of the data, 97 patients were enrolled on this study. The cell dose was 0.5 to 1 million per kilogram. The overall response was an incredible 97%, but again, one should not compare between 2 clinical trials, but it was impressive. The stringent CR rate was 65, 67% of them achieved a stringent CR. Time to first response was 1 month. Clinical improved over time. That means the majority of patients, even after the initial assessment, continued to show improvement over time. The 12-month progression-free survival and overall survival, and what's in brackets later at 27 months, was 77% and 89% at 12 months, and 55% and 70% in the long-term follow-up data. Grade 3-4 hematological toxicity was seen in 95%. Again, the same story. Majority, it was mild. And the CRS was also mild in the majority, and a small proportion was grade 3-4. 1 patient had an immune effector cell-associated hemophagocytic syndrome and died. 20 had neurological toxicity. 14 died overall with a combination of toxicity and progressive disease. There are a number of ongoing studies, but just stopping at these 2 approval studies that led to approval, fairly impressive data when you look at the fact that these were heavily pretreated group of patients. There are a number of ongoing trials with CAR-T, which I'm not going to walk through in detail, but just to say that there is just an incredible number of studies of using the same agent with different combinations, etc., that are going on. This is just a small list just to illustrate that concept. There's Captogen Autoleucel, which is a Juno therapeutic product. There's BB21217. It's the same construct as the Idacil, BB2121, but includes incubation with a phosphoinositide 3 kinase inhibitor that enhances the persistent memory phenotype of CAR T cells that's going on. There's a construct targeting GPRC5D. There's an allogeneic CAR-T along with a SLAM7F CAR-T, which in the allogeneic one, they're trying to knock out the MHC receptor on the T cells to make it a universal CAR-T. So these are all studies that are going on. This is a list of studies. The idea is not to go through this in detail, just to highlight that you can recognize from here the ida-cel study and the sita-cel study, and you can see the origin of the antibody that they had tried. This is not single chain fragment variable. In the case of the llama here, and in the sita-cel, we know those are nanobodies, which is just the variable heavy chain that has been used. The only point that I want to highlight is that the overall response is very high, but the median progression-free survival is not so good in the ones where there has been reasonable follow-up. And so the take-home point really is encouraging results and an option in heavily treated patients. What I mean by that is, in these heavily pretreated patients with practically no other option, you now have an option of therapy and a subset of patients. Even though the median duration may be 8.8 months to 11 months, there could be a subset of patients who could have durable response. Longer follow-up is required to make a more conclusive statement on that. But much more important is the excitement that we have in other strategy, and we can optimize strategies, how to optimize, whether it's with combination with other agents, optimal dosing, scheduling, and far more important, what is the appropriate time to deploy these technologies? As all of us who treat malignancies know, you take relapsed refractory patients and you do anything, nothing good is going to come out of it. So probably as we move earlier and earlier into these trials, use them as combination, use them as bridges to additional therapies, we probably are going to see much better responses. I'll talk a little bit about a case that we treated as part of the Origins trial. This was a 58-year-old lady, a doctor, who was diagnosed in 21 with an M-band of 5.88. I'm not going to read through all this. She was fairly well. She did have some hypothyroidism or type 2 diabetes, but her performance score was quite good at the start. She had multiple lines of therapy and her M-band really did not improve. She initially showed some improvement when we were planning to take her up for an autologous transplant. We saw that her M-band was climbing. In 22, therefore, we gave her DARA-based therapy. There was also issues with her ability to stay here because she was based in Dubai. She went away. She came back with, again, persistent disease and was progressed outside and then came to us. And then we gave her DARA-DCEP. She had an autologous transplant. At autologous transplant, we had got her down to a PR status. But within 11 months, she relapsed at 4.96 grams. She had KPD2 cycles, really not much response. Truly a heavily pretreated patient, refractory in a sense to all conventional therapy. So we consented her in December 23, and we infused her with the product. The details of the lymphodepletion and the bridging therapy are there. And we gave her a 5 million CAR T cells. She really tolerated it quite well, except for a prolonged cytopenia. Had a grade 1 CRS, and she had to go to ICU because she had developed fever with the cytopenia. But overall, it was a learning exercise as well for us because she was clinically quite well. It was just the cytopenia that worried us initially. So if you look at her total WBC count, she's about day 150 now. She still has a lowish count, not completely normalized. The ANC is about 1,000, but the IL-6, you can see, goes up very rapidly and then comes down. And by day 14, it's practically normal. She has an absolutely excellent performance status, and she's back to a normal life. She's back in Dubai practicing, and she comes every month for her study-based checkups. If you look at her M-band, and I highlight these dates specifically because this axis is not linear, it's just showing the different lines of therapy. In September 21, that's where her M-band was, and then it came down, but it never really got her into anything, got her anywhere near VGPR, it was always in PR. Pre-transplant, she was about 0.94, and within 10 months of the transplant, her M-band had climbed to 4.5 odd. And this was the time when she was actually taken up for the CAR T cells. She was infused CAR T cells in December 23, and you can see how the M-band has dropped. And also important to highlight the continuing drop. Every time we see her, it's practically just about detectable. So technically VGPR, but she's practically in CR with an excellent performance status. She's clinically doing very well, no adverse events or serious adverse events after that initial period, and we continue to follow her up every month. Just touch on toxicity. There are some variations. Again, most of you all know you're dealing with a live cell, live drug, which continues to proliferate and grow within the body. So it doesn't follow the conventional PK/PD of other small molecules. These cells can also proliferate, and you can see various effects at different time points. This cartoon just highlights the different time points, the different kind of toxicities you can see. One, of course, we have the on-target, on-tumor toxicity. That in the case of CD19 will be targeting the leukemic cells and the lymphoma cells. You can result in tumor lysis. What you need to remember about tumor lysis with CAR T cells is when you have bulk disease, unlike with your conventional chemotherapy, you can continue to see tumor lysis, especially when you have disease that has not been well reduced before CAR T cell, persisting for weeks. So you must be conscious about it. And of course, you can get on target off-tumor toxicity, as in the case of CD19 against normal B cells, and you have to handle that. The usual CRS and cytokines, most of you all are familiar. You all have had series of talks over the last few days. I'm sure those have been covered in great detail with regards to how to stage it, how to manage it, when to use steroids, when to use tocilizumab, and when to use anakinra. I've not used anakinra, I've not had the opportunity to use it, but we have fair experience with steroids and tocilizumab and how to go about it. I just like to highlight on immune effector cell associated hemocytotoxicity because we did see it in this particular case more than we saw it with our CD19 patient. So obviously the patient is absolutely well and you don't have to panic or react too much. It increases and improves over time. But for those who are interested, there is a grading system. Remember, the first 14, 15 days, the effect of the cytopenia is due to the lymphodepleting protocol that you use. But the later onset, we know, is an immune-mediated phenomenon and can last up to anywhere between 3 to 6 months as well. So this reference has it for those who are interested. But I just highlight on the early cytopenia, mid cytopenia, and late cytopenia. Early, as I said, is usually due to the chemotherapy. It could rarely be to a hemophagocytic syndrome. But the intermediate one, beyond day 30, you need to keep your mind open for an immune-mediated suppression and autoimmune-mediated phenomena, just like autoimmune hemolytic anemia with the other cell lines. You have to look out for an LGL clone. You have to keep your mind open for a thrombotic microangiopathy kind of phenomena. And once you diagnose all this, I'm sure you will know how to treat it. And some of these immune-mediated cytopenias can persist even beyond 3 to 6 months. So optimize and stabilize clinical condition as much as possible prior to CAR T cell therapy. Try to change to a short-acting insulin and antihypertensives if possible. And the reason I say this, if a patient deteriorates rapidly with a CRS and goes to renal failure and he's on a long-acting insulin, you really don't know whether he's actually going to an ICANS or whether it's hypoglycemia or it's a long-standing hypertensive worsening the hypertension that has been generated by the CAR T cell. So it's good to change to short-acting insulin and antihypertensives. Give bridging therapy to get the disease under control as much as possible. The CAR T cell infusion and tolerance goes better. It is not about individual glory here. You have to train your entire team from the first person on call who sees this patient to the nursing staff to monitor closely. Very clearly, we know that early diagnosis and intervention is key. And remember, it can happen within few hours. I'll just illustrate a case. We had a patient who was, I think, WellCART 06 on our study. We infused an ALL, we had bulk disease, totally refractory disease. We infused him, and the patient actually said, "Is this all CAR T cell is about?" And 7 hours later, he was in ICU with hypertension. So things can change very rapidly at times with these therapies. You need to keep your eyes and ears open. You need to intervene early. I'll stop here and thank. There's a lot of people who go behind in my team who make all this possible. Collaborators, Milteni, and of course, Origin Oncology, Dr. Akhil especially, who has been working very closely with us for this present ongoing trial. Thank you for your attention.
Thank you, Vikram. Wonderful, beautiful. We'll discuss this during QA session.
Sure.
So now I invite our second speaker, Padmaja. Please go ahead.
Thank you. Thank you, Agrawal sir, for giving me this opportunity. And thanks, Vikram. You've made my life much easier. You've gone through overview right from the production and the therapies and the other areas of toxicity. So I'm going to mainly focus on the therapy for myeloma and 2 of my patients' experience and some of the nanobody things which I wanted to talk, which have already been covered. So the first Origin Oncology DRL, some of the slides were provided by Akhil, who is head of Origin Oncology, to review some of the data. So this is a DRL 1801. It's an anti-BCMA CAR-T manufactured within India. This is ebricaptogene autoleucel. The DRL 1801 is a study which is phase 1/2. This initial development has happened in China, and which was technology transfer has happened through Origin. This is the phase 1. The initial data I'll present, which was from China, which is quite relatable to our trial. The current trial is a DRL 1801, a phase 1/2 open label multicentric study evaluating the efficacy and safety in patients with relapsed refractory. In this trial in India, we have taken more than 2 failed cell line therapies, and there are patients who are more than 6 failed therapies who are enrolled in the trial. So far, 8 patients have been dosed and 2 failed manufacturing the CAR. And the poster has been presented and accepted at International Myeloma Society in September. So they could not give me the full details to present, as it's not been out in the domain. The current data is submitted, and we're waiting for the next phase to be opened, hopefully at the end of August 2024. So we just spoke about Rebrecel CAR structure, which is quite different. The VHH nanobody, which is quite similar to CARVYKTI, using this nanobody to have a better low immunogenicity, better effectivity, and has got similar to CARVYKTI. The nanobody is used with response rates of 98%, and our current Origin product also have got a similar response rates compared to the one which is used SCFV domain. The phase 1 clinical trial data from China, which shows a good efficacy profile. They've used a different cell doses of CAR-T, which is 2.5 million per kilo, 5 or 10 times 10 power 6, 10 million per kilo. In our trial, we have been using 10 million per kilo dose. Compared to different trials, if we look at a CD19, a lot of cell dose has been 3 million, but in myeloma CAR, it has been, the DRL product has been a 10 million cells. And the CR rates, quite usual. The dose has been chosen at 10 million because of the efficacy compared to multiple trials as well. The preliminary results of this current trial is quite similar to, and looking at the VGPRs, about 20 to 30% had a VGPR, but the response rates have been quite 80 to 90%. But the CR rates are about 40 to 50% across the group. If we look at the CRS, the number of patients who had CRF is 85%, but the grade 3 to 4, which is severe, are only 1% in the Chinese trial. Again, in our current trial, the initial phase, which showed a no grade 3 or 4 CRS, but there are significant number of, quite 80% of them have got grade 1 to 2 CRS and none ICANS. This is a phase 1 trial of China showing a persistence of BCMA CAR close to 800 days after infusion. And in the current DRL trial, they are going to continue the PK profiling of the patient for close to 2 years in the Rebrecel group as well. So coming to my patient, this is a 56-year-old lady with a background hypertension, diabetes, hypothyroid, was diagnosed in October 2016, treated because she comes from distance and she couldn't afford. So she had a oral chemotherapy, gone into CR, and followed by auto transplant. And she had a relapse. After 4 years, she has relapsed in January 2020, treated with a VRT chemotherapy for 3 cycles until April, but didn't have a much good response, had a serological progression, moved on to Carfil-Pomdex, still had a suboptimal response. Then she moved to Dara Carfil-Dex until December 2020. She still had a persistence of disease. So she kind of had a refractory disease continuing from VRT to Carfil-Pomdex to Dara Carfil-Dex, and moved on to a heavy doses of chemotherapy with 2 DT-pace chemotherapy cycles. At that time, we are talking about enrolling her into one of the clinical trials. She had a second auto BMT in July 2021, followed by maintenance. The second auto transplant has given her another 1.5 years. At that time, she started having a serological relapse in December with a rise in light chains and M protein and a marrow showing 28%. So this lady is a heavily treated for whom we considered for clinical trial, and she enrolled into a CAR-T trial. We did a cell collection on the beginning of January. We did an in-house CD3 numbering. We had a 2 times 10 power 9 CD3 estimation, and we sent it to the central laboratory. Within 72 hours, they would confirm the quality of the product and they would start the manufacturing. In the DRL process, within 14 days, they would say that they've got the good manufacturing and we can start the pre-CAR medical assessments. At that time, you would start doing the bone marrows, the serological assessments and the PET-CT, and would admit the patient for lymphodepletion. At least 1 day prior to giving the CAR T cells, the cryopreserved product will reach your site to be delivered. And a 3 days lymphodepletion therapy in this trial, fludarabine 30 milligram per meter square and cyclophosphamide 300 milligram per meter square on day -5, -4, and -3. This LD chemotherapy can be a little bit different. Sometimes we give 500, but you only give 2 days. But in DRL trial, we give 300 for 3 days. And there are 2 rest days, and then you would give the day 0, that is on 3rd of Feb. So one different thing what we noticed is compared to the stem cells, the CAR T cells are quite viscous, and sometimes you might find it's very difficult to infuse through the PICC lines or the cannulas. So keep your lines patent. Once you thaw the product, you cannot keep it more than 20 minutes. You have to infuse it. So you have to have a backup option available, keep the line flowing, and also keep a 50 ml syringe, everything as a backup. So after the first product, there was a difficulty in infusing. Hence, we started using a sterile. We use it in the laminar flow. We collect it into a 50 ml syringe and we infuse it over 15 minutes. That's what we've been doing, and run the saline flow through the same to avoid any of these delays. And the certificate analysis of our patient's product, we've got the cell count of 10 times 10 power 6 per kilo body weight. And we've got a good cell viability, CAR positivity rate close to 70%, and SCD3 positivity. And you would also get the microbiological testing of mycoplasma, and the replication component of the lentivirus should be negative, and the CAR gene copy should be less than 5 copies per cell. This is a quality criteria for release. So this patient, day 0, patient had a good normal counts and has achieved a low lymphocyte, which we are giving lymphodepleting chemotherapy. After day 1, I just thought it'll be good to see the real case in a day-by-day progress. So day +1, patient had a vomiting, 2 episodes. Day +2 onwards, in the initial first 7 days, patients tend to have the CRS and problems in a myeloma CAR with a bigger doses. The day +2, patient started having fever spikes, headache. She had a CRS grade 1, ICANS 0. And since there is a fever, we sent blood cultures and started PIPTAS. And day +3, she continued to have fever spikes and she dropped her blood pressure 100/60. She's known hypertensive. The first thing, we stopped her antihypertensives, kept her on fluids. We were ready with the tocilizumab. The dose of tocilizumab would be calculated and written in the drug codex with a qualifier that it has to be given only after approval of the consultant, hematologist, or an ICU consultant as a second line. So there is no delay if there was a requirement. So the drug is kept ready on the ward, and orders are written to be given when there is an approval. Blood pressure improved, so we did not give tocilizumab. On the day 4, patient continued to have a low-grade fevers. So we continue to observe as the patient continued to be well despite the fevers. We kept waiting, thinking that the toxi may cause her increased risk of infections in future as she is heavily treated. On day 10, patient had a diarrhea, few episodes, no major concerns. Patient has had a cytopenias, which improved by day 14. She got home. She was monitored as an outpatient on a twice-weekly basis. She did have an on and off fevers, which are low grade, close to 100, and dizziness, headache and dizziness time to time, which we managed with stockings, hydration, high salt diet. She went to ENT, started on Vertin tablets. Later on, after a month, 2 months, it completely settled. It could well be an ICANS, a low grade, which we couldn't pinpoint what it is, but it settled as the time went. So this is a IL-6 trends. Initially, patient had a high ILs in the early phases. It settled completely. My patient, after 4 months, she had a high IL-6. I'll tell you what has happened. These are the ferritin trends. So these are the prophylactic medications. All the patients are on anti-epileptics for good 30 days, the moment they come in, and the PCP prophylaxis until the count recovery. So this patient, day 28, she went into complete remission, MRD negative at day 90. But day plus 64, she was admitted with a fever, headache, and a severe cytopenia with a 9,000 platelets and had a liver enzyme abnormality. At that time, she was noted dengue positive. We thought it would be a short admission. We've given her platelets, but she was platelet refractory. Platelet count was not increasing. So we thought this could be an immune phenomenon during dengue. So we've given steroids, no improvement. She was managed conservatively. She took 6 SDPs, stayed in the hospital for good 2 weeks. Slowly, her platelet count stabilized at 30. So we discharged her and put her on TPO agonist. She took close to about a month and about 40 days to recover her platelets completely. So we started wondering whether this is a secondary marrow-aplasia, not just dropping the platelets. She also had a leukopenia, which took a bit longer to recover. Whether this is a known phenomenon in patients to have a secondary marrow-aplasia post-CAR, as a CAR continues to expand for over a period of time, or is it an exaggerated effect of a dengue when in these patients with altered immune system with a CAR? So these are the counts just to show how the patient had a platelet counts completely normal, a complete recovery, and then a drops which continued for a while before the recovery. So currently she's 6 months post-CAR, and she had a recent assessment. M protein is not visible. Her kappa lambda light chains are below the normal ranges, which again depicts a complete B-cell dysplasia, complete B-cell aplasia, sorry. IgG levels of 141 in contrast to normal. Currently, she has not had any major infections and she's continuing to be well, but we have had a prime up if there was an increase in risk of infections. She did have one UTI. She kept on nitrofurantoin prophylaxis. If she had a multiple infections, being a diabetic, we were contemplating on IVIG maintenance at 0.3 per kilo dose every 6 weeks, but she did not need it. This is a timeline of CAR T-cell therapy, which takes within 2 weeks. Things are better, so hence we tend to discharge patients after 2 weeks of CAR T. And these are the reported toxicities in all the clinical trials. Time of onset is 1 to 7 days, most of the time for CRS. For ICANS, again, within 8 to 10 days, the CRS is finishing between 2 to 8 days. At our center, we block a bed in ICU from day 3 to day 7 to 8 for a potential CAR T patient. And we've identified a neurological consultant for the CAR T and an ICU consultant who are aware of these patients. As Dr. Vikram said, patients can drop down very quickly. So things have to be in place in your absence in the hospital. So this is just a depiction of CAR T CRS assessment, the temperatures, hypotension, and a hypoxia. And this is what we have designed as our CAR T protocol for nursing assessments, where the nurses will do ICE scoring every day, 10 out of 10. There are 3 columns of this, which they do it 3 times a day, along with a writing of checking the writing. There are 3 other columns on the opposite side of the patient, and this is a daily ward round picture for the CAR T cells. I've designed these, taking some of the information from Manchester, where I worked for 5 months as a CAR T consultant in 2021. To tell you, in 2021, even the best of the centers in UK weren't doing a myeloma CAR. They were doing lots of CD19 CARs. So we're not far off. Coming just about a year and 2 years down the line, we're doing myeloma CAR in India. So this is the depictions of how we manage. So one more thing I would like to say, in the trial, definitely we go by the guidelines of giving tocilizumab 8 milligrams per kilo. But in a commercial patient, because of the cost difficulties, I kept 200 milligrams the vial comes. So I always keep a 200 milligrams as a start dose in the drug chart. And we can always repeat it if it is required. So that's my personal choice, but the recommendation is 8 milligram per kilo. In most of the 50 kilo patients, you get about 2 vials to be used. And this is our ICANS assessment. So the second patient I would like to say is a 46-year-old lady who's a refractory myeloma diagnosed in January 2020, had a VRD, transplant, LEN maintenance, and had a relapse. A very short time. She continued to have problems and a KPD regime till December. And she had an ongoing multiple bony lesions with a progressive disease. Hence, she was started on DARA cyclodex. She came to me for consideration of CAR T trial in May 2023. So at that time when she came, she had a heavy light chain disease of 1,000. Pending the trial enrollment, we gave her PAD chemotherapy to get her into remission. She did drop her light chains very well, and she continued to have ECOG of 0 with a good performance. And pre-CAR assessment showed a heavy marrow disease. We collected the T cells, very good T cells, and we were off chemo-free period of 2 to 3 weeks prior to collecting. And she had 1 cycle of bendamustine as a bridging after the collection. But unfortunately, her CAR T cell manufacturing have failed. They've done extensive studies. We're not sure whether it's because of anthracycline or because she has got an extensive disease or it's to do with the microenvironment. DRL thinks that it's a production bag, which is an issue, and they're going to change the way they're producing by using G-Rex to have some more automation into the process. These are the different ways. And according to the literature, it is very well known the BCMA CAR-T production failure is there in good number of patients. It has occurred in 10 patients in one of the Janssen reporting. And it also says 20, in another journal, it showed about 25% of patients have failed to manufacture CAR-T and BCMA CAR-T. So this could be due to the refractory, relapse refractory, or T cell fitness, or due to the microenvironment or variable reasons. So with that, I would like to say it seems very easy to give FC chemotherapy for a CAR-T patient, and we need to identify a right patient. And also PFS being such short at this time, we have to be mindful of using the resources at the right time. And given the toxicity being in a smaller group, but it could be a potentially life-threatening, to have all the belt and bracing and have the protocols updated and all the multidisciplinary team aware of all the complications and timely interventions, and not to give steroids very early to lose a precious CAR product. So with that, thank you very much. I'm going to leave it open for the discussion.
Thank you, Padmaja. I think 2 of you did a great job. The 2 was additive, synergistic. The way you approached it day to day, what was happening to your patient was an eye-opener. I'm sure all those who are listening and who are curious, when they would do the CAR-T, have learned a lot from you. So thanks to both of you, and thanks to everybody who has been now very excited and talking about CAR-T all around the country. So let's have some question answer session. Use the raise hand sign, please, so we can go over the questions. I do know that the experience of all of us is negligible, so you may feel shy in asking questions, but your difficulty is difficulty of everybody. So please go ahead. You've got 2 experts here. You've got other people who are involved with CAR-T, and they may also chip in. Aditi, go ahead.
Thank you for the very informative talk. So my question is based on a patient that I am managing. So he's a 62-year-old male. He was diagnosed with multiple myeloma amplification 1Q about 1.5 years back, received bortezomib, cyclophosphamide, dexamethasone chemotherapy elsewhere, and after 2 months he defaulted. Then he visited me at about February 2024 with a florid disease. So kappa light chain was 14,000, marrow cells, severe cytopenia, multiple lytic lesions, and he was almost bedridden because of the pain. Started him on daratumumab, carfilzomib, dexamethasone, and plan was to do auto transplant after achieving remission. After 1 cycle, the kappa light chain reduced to 2,000. And then again, after 3 cycles, I repeated, the kappa light chain again increased to 6,000. And even the M spike had come down after 1 cycle and again started rising after the 3rd cycle. Simultaneously, he developed acute hepatitis B infection. So started on entecavir, and at this point in time, what would be the treatment and what is the role of CAR and outcome with CAR in such a patient?
Okay, Padmaja, go ahead, and then we.
This patient has got a refractory disease. And for going on the trial with an active infection, it could be a challenge with an active hepatitis B to go on to the T-cell therapies. And the second thing, you need to be off treatment for at least 3 weeks, 2 weeks minimum for patients to go on the clinical trial. And they need to have a good performance score for going on the clinical trial. So this patient would not be eligible for the way bedridden unless we give something and his ECOG performance improves. Yeah, he could be enrolled on the other clinical trials. So we've got a AUR107, which is a bromodomain inhibitors, which the dose escalation has happened from 10 to 20. So that's one of the options for you, or the tri-specific antibody trial, which is opened, that could be an option. But all these clinical trials, for you to have an ECOG of 0 to 1 would be a big challenge. So it is difficult for this patient. I think first you have
Status did improve after
Okay.
3 cycles. Only thing is that his response was not there in terms of the light chain assays and M spike. They were rising.
So you got to get into one of the clinical trials when his performance improves. I think get the hepatitis B, not that active to enroll. That's what I would have thought. I would love to hear what Vikram says.
No,
Thank you.
I really don't have any answers. You're dealing with a relapsed refractory disease who's progressed on Darapom Dex, if I remember right, and whose performance score was very bad but has improved a little bit. If his performance score is good, you could consider, intensifying. There's no point doing an autologous right now. You probably will not even get enough stem cells. So if his performance status is improved and is pretty good, you could even consider Dara DCEP or something like that to intensify therapy. But the probability that he'll tolerate it is only you can make that call. Difficult to say from outside. If you can access bispecifics and if resources are there, you could try some of them, the Latinib, etc. It's not easily available, but those are some of the more like clinical study kind of options. But conventional options are fairly limited. You've not tried KPD, if I remember right.
Sir, daratumumab, carfilzomib,
You tried.
dexamethasone.
Okay.
Yes, sir.
So you already tried that. Yeah. So your options are limited.
Take a question
I
from the
want to
audience.
say,
Thank you, sir.
can I say something, Vikram? What I found, patients with mezigdomide carfil dex are doing really well, but they should not use carfil beforehand, but they have to use bortezomib, lenalidomide, and daratumumab. They have to be a daratumumab failure, but not
Which drug did you say?
bortezomib.
Sorry.
Then
Which drug did you say?
this is a successor 1, successor 2 trial with a mezigdomide carfil dex. Patients
have
are
no
doing
experience.
really well. We had the
Okay.
trial going through, but
Okay.
they have to be Dara refractory, but carfil naive.
Okay.
To take a question from the audience, Dr. Kanan wants to know, how do you compare bispecifics with CAR-T? So Vikram and then Padmaja.
I don't think we have the answers yet. There are pros and cons. What we know from the available data is that if you give CAR-T cells after bispecifics, the response is not so good, but the other way around does not seem to be too bad. So we really don't know which to use first and what is the best way to go about it. But from the available data suggests that BCMA, at least in the BCMA CAR, does worse after a bispecific, the response is less. But if you already had a bispecific and you use a BCMA CAR, its response seems to be better. So maybe in terms of sequencing, if all therapies are available, you may want to consider the bispecifics first. But I don't think the definitive head-to-head comparison data is.
Padmaja.
I would have thought so, yeah.
Okay, one more question from the audience. How do you decide on starting antibiotics post-CAR-T febrile neutropenia? Do the biomarkers help you?
I'll take that. So basically, it's just like a transplant or an aplastic anemia with ATG, for example. When you have fever and you're neutropenic, you assume it is sepsis. And you follow your febrile neutropenia protocols, immaterial of what the biomarkers show. And subsequently, your cultures will guide you whether to stop your gram-positives and change your antibiotics, etc. But once you're neutropenic, the febrile neutropenia protocol kicks in.
Padmaja?
Yes, absolutely. And prophylactics, all the patients go on antifungal prophylaxis, antiviral prophylaxis prior hand. And sometimes, if you've witnessed a grade 3, 4 CRS once in your lifetime, you know how bad they can be. You just look at them, you think they're shivering with a high-grade fever. This looks like a gram-negative sepsis, but they crash very quickly. It appears very similar to a severe gram-negative sepsis, even a CRS of grade 4. And when you act timely, you can rescue them not going on a ventilator or iron drops. And
Your comments on biomarkers, do they help you?
Certainly, we do now as a routine practice for all our cars. Monday and Thursday, I do all the biomarkers of IL-6, ferritin, and NT-proBNP, and the CRPs. That is just to give the trends, but it is all about in the context of clinical case you would act upon. But it's just for you to know whether it is an infection, whether it's a CRS, to guide you. Sometimes a procalcitonin also can help, but it's nothing an absolute, but these are all for you to make a judgment based on all other things.
Thank you. Dr. Nishad, your question.
So outside the clinical trial, do you see any exclusion criteria for starting, considering a patient for CAR T-cell therapy?
Vikram?
Yeah, so if the patient's, very heavily pretreated, very poor performance score, you may not, first, you may not even harvest enough cells. You may have a challenge getting you onto an apheresis machine and, getting adequate cells. Very poor organ function, you may want to think about it. There's nothing like written absolute, but it's a combination of factors.
Padmaja?
Absolutely. And one more thing, whether the patient should be close to you at least for about 1 to 2 months. In the hospital for 2 weeks. After that, they should be available for a month, as the CRS can happen even as an outpatient. They should be available to have an access to care. So they should be in a reachable state for about a month to 2.
What about cytopenias? Like, do you have any cutoffs?
So in cytopenia, it is all up to, is it because of the heavy disease? If you've got a cytopenia, you could still go ahead in a young patient, but your chances of PFS is very low. So one has to be aware of that. And yeah.
An extramedullary disease?
In a lot of trials, it has been excluded. So we probably don't have a data about a multiple plasmacytomas, plasma cell leukemias are all excluded from the trials. So we don't have a data to say whether it'll work or not. Yeah.
There's some BCMA early trial data with extramedullary disease showing promising results. But again, I think as Padmaja said, we need to see larger.
A question from audience. Can you predict the manufacturing failure of CAR T prior to apheresis? Vikram?
People have tried things to look at proliferation of T cells, etc. But I don't think there is a very strong and accurate thing. So people do, if you don't get enough cells to start with, then that's a good indicator that you have a problem. People who have had, and you try to avoid very intensive therapy with bendamustine, lenalidomide for a very long time, etc. If you have CAR T cells in your horizon as an option, because those really do bang up the cells. I know people do T cell proliferation studies before they take, but to be honest with you, I'm not sure, how effective they are in what's their positive predictive value, for example.
Padmaja?
Absolutely, as Vikram says. But would that be ALC count, absolute lymphocyte count, less than 1 prior to collection? We probably say because of heavy steroid doses, we have to stay off steroids at least for 2-3 weeks for the lymphocytes to recover before we can collect the T cells. Or ALC count less than 1,000 could be a very difficult to collect. Those are the 2 other things, other than the heavy treatments. Yeah.
Rajat, your question?
Yeah, so for leukemia, BALL is now coming much more upfront in treatment, and that's what the world is moving. Is that what is going to happen in myeloma as well? That you have? Is that going to be a permanent cure for myeloma if you use it much earlier?
There is a trial
Any
going
idea?
on. KAMA4 trial is looking at an upfront BCMA, but we don't have the outcome yet.
Dr. Usmani had presented their data right in the first line for patients who have got very high risk, ultra high risk myeloma, and looks to be promising data, though early days. So they have moved right from after 4th line failure to 3 line, 2 line, and upfront for this group of patients. That probably had to happen. A question from audience. Does radiation and lenalidomide impair T cell fitness as it happens for stem cell collection? Vikram?
So nobody has systematically studied it and said this much lenalidomide, you will get a failure. But we know in general that when we do lenalidomide long time, we have problems with even mobilization of stem cells. So bendamustine for sure, we try to avoid. And lenalidomide, long use of lenalidomide probably does affect stem cell fitness, and that in turn probably affects lymphocyte production. But again, very difficult to say not to give lenalidomide, for example. That would be too harsh a statement.
Padmaja?
Yeah, is it to do with the T cell exhaustion? And people were talking about collecting the T cells and harvesting them upfront before heavily treatments and using it for a later date for a T cell, CAR production, so that they're fitter T cells than the fatigued and exhausted T cells. So I think that's.
Another question from the audience. One was about PCP prophylaxis, which you already mentioned. And second is about vaccination schedule that you follow. So Padmaja and then Vikram.
We got to, NHS recommendations are that you got to wait for the B cell recovery before the revaccination. So that could be a bit variable from patient to patient. Generally about like transplants, it takes 3 months, but some could take a bit longer.
Vikram?
Yeah, I agree. I mean, from 6 months to 1 year, you would consider, but it will depend. If there's total B cell aplasia, there may not be much point in pushing that beyond.
The question is whether in high-risk myeloma, CAR T is going to replace upfront ASCT. I think we already discussed that. Ashish, your question.
Yeah, thank you. One question to Vikram. You're going to have availability of bispecifics also now. So when you have availability of both bispecifics and CAR T at the same time, how are you going to sequence? Are you going to use CAR T first and then bispecific as a backup, or the other way around?
Yeah, Ashish, I don't think we have the answers from the literature at this point in time. What is the way to sequence and what is the scheduling? But what I said a little earlier was there's some data. Please check this out independently. That if you use CAR T after bispecifics for BCMA, the responses are poorer. But the counterwise, that if you used, I hope I'm getting this right. If you used your alatinib later, you still have responses. So for that reason, you may want to go CAR T cell first, but the reality will be what is actually accessible to you and at a given point in time, and what is the cost, and so many other factors. But please check this out for yourself. I think there's some preliminary data along this line.
Right. And with the trial running, how are you sequencing, say, if that's a young patient and you can consider for allogenic transplant in that scenario? Would you still choose allogenic transplant in that scenario, or you will not?
Yeah. So, allogenic is really a rarity even for us, to take for myeloma. In a young patient who has achieved a very good response, we may think about it. I don't have the answers. I can tell you for the ALL, the CD19 story, again, there's not based on a systematic analysis, but some centers would certainly use the CAR T only as a bridge to an allogenic transplant. The better the MRD negativity you get with a good donor, the better the long-term outcome. Though the studies comparing this head-to-head have shown no difference. But for example, I mean, Fred Hutchison, for example, regularly would do a transplant after a CAR T in adults for sure. So we don't have the final answers on what is the best way to sequence this, or should we sequence it?
Sure. One question with Padmaja for any comments on prophylactic tocilizumab, the way we can use in bispecifics?
I don't think, because it might suppress your immune system and you're more at risk of infections. And who knows, the TB is a big threat for us. Especially we have seen after multiple uses of brentuximab in Hodgkin's, the amount of TBs you get after JAKs and, so I would be very reluctant to give tocilizumab. Henceforth, even in my patient, I was waiting to see the tipping point before I give it. When you give toci, even in haplos, you see how the fevers vanish. Even in a patient with a sepsis, you give toci, you might just vanish the fevers. That's what because you're suppressing the whole of the cytokine storm. So that could be an alarm on the opposite end.
Thank you.
Thank you.
So teclistamab has become available from today from Janssen. So your question is quite valid. Is myeloma CAR-T available in the country outside trial at the moment?
I don't think so, sir.
Nowhere. Okay. So Ashish, you can use bispecifics because there is no option at the moment. Okay. Dr. Ashok Meshan.
Good afternoon, sir. Thank you, Vikram sir and Dr. Padmaja for a very informative lecture on CAR-T cell. So my question is regarding the long-term risk of a CAR-T, like risk of a second tumors and T-cell lymphomas after CAR-T cell therapy. And for what type of monitoring do we need in a long-term follow-up of such patients?
Yeah, so Padmaja silence means
No, I could say there was a paper on triggering the concerns of the T-cell malignancies post-CAR, but that's only a couple of patients. And after that, we've done more than 10,000 last year, the data. There are hardly a handful of cases of this. So they said it could be a coincidental, it's not as, causative. So the flag was raised about a year and a half ago, but that's not an ongoing concern now. Yeah, but the big problem for myeloma CAR is the PFS. PFS are not that long. We're not talking about secondary malignancies. We're talking about this disease curative nature and the relapse and what else we need to use post-CAR, maybe a year, 2 years down the line to potentiate. So that's what is our biggest challenge. I've read some literature about using lenalidomide or ibrutinib to potentiate these CAR cells to give them a longer, nature, but I still need to go into the depth of to use in real life. I don't know, Vikram, whether you've had. I consider.
Basically, Dr. Ashok, I don't have the answers, but the second malignancies due to CAR-T per se is, I think, very, very rare. So there have been one reports, and I think some of them are related more to the transposon-based ones in Australia. If I remember right, I'm 100% sure about that. But with regards to monitoring, you have to monitor these patients very long term. You have to replace immunoglobulins if the values are less than 400. So every 3 months, we will follow them up. And many of our patients on our CD19, we continue to monitor and follow them up regularly. They're absolutely well, but you still need to see them regularly.
Thank you, sir. Thank you very much.
Thank you, Ashok. Another question from audience is related to, is pomalidomide also toxic to the stem cell and T lymphocyte?
I suppose it's very similar to lenalidomide. So
Vikram,
probably less, it's probably a safer drug than lenalidomide in that context. But again, we really don't have any head-to-head comparisons or data like that.
Another question is, post CAR-T, do you monitor for CAR-T percentage in the peripheral blood? And if yes, do you act preemptively on any value?
So as part of the earlier trial, you can do this by flow cytometer, at which time the detection level drops after a certain point. But if you can also document it molecularly by doing a cDNA and doing it compared to a baseline total DNA and as a percentage. And so you can track cells for a very long time with both these, and we know that they persist in a proportion of patients for a very long time. In the majority, again, BCMA, I'm not very sure. Majority in the CD19, quite of them may not be detectable after a certain period of time.
Padmaja?
In the Chinese data, they showed up to 900 days the persistence. In the trial, they're doing the continuous monitoring on a monthly basis. They're taking samples in the DRL trial initially and later on every 3 months. But I asked ImmunoAct about whether I could have for a commercial patient to monitor the CD19 CAR. You have to pay some amount. Yes, they can monitor for your patient. It is costing about close to 40,000. When I told the patient said no need to monitor.
Second part of the question was, do you act preemptively on any particular value?
No. If it's validated, then, but we don't have a validation, definitely.
No, Padmaja, if your CAR T cell level falls, what are you going to do?
But do we have a validation of this level? If it is validated in the trial, like how the Fred
No.
Hutchinson
The
data-
point I'm saying is, outside a clinical trial, if your level becomes undetectable at 4 to 5 months, so be it. And that's it. There's nothing more you do about it. And nobody is saying because it's not detectable, you have to go and infuse again. People have tried different strategies to expose to stimulation to the existing cells that may be there to make them proliferate more. But on a routine basis, you monitor the CAR T cells for the sake of monitoring it. I'm not aware, please correct me if I'm wrong, of any intervention on a regular practice outside a clinical trial if you can't detect it.
Thank you. There is a question outside the discussion today is about pediatric CAR T and the results from India. You want to answer that or leave it for some other day?
We've treated one patient on our trial who was an early refractory patient, is doing absolutely well. And initially we wanted to bridge for transplant. We didn't transplant. The patient is more than a year now, who would have been dead long ago with any conventional therapy. It's absolutely well. I don't know the other pediatric data, but I think it works equally well in children as it does in adults.
You're talking about BALL?
B, not myeloma. No, myeloma.
BALL,
No,
right?
pediatric.
The question is for BALL.
Yeah, BALL.
Padmaja, any data from your center on children with BALL?
19-year-old patient had a marrow disease post-transplant, early relapse post-allogeneic stem cell transplant with CNS disease. Patient continued to be well for about 4 months, but started having a relapse in the CSF. So there is still B-cell aplasia, the marrow is negative. He still got a T-cell cell aplastic marrow, hyperplastic marrow from the CAR, but the CNS disease seems to be a very difficult one. We continue to do ITs now. So we face this challenge, and just before giving the CAR, we did a CSF just to check. He was negative prior hand. And just before infusing the CAR, we did it, and it showed cells. So we did not give IT methotrexate. We discussed with Manchester. What was told that there is a lot of CAR transferring. I think I discussed with Vikram as well. There is a CAR transfer to CSF. So they suggested to do every 2 weeks CSF to see the clearance and to do a flow to look at the T cells in the CSF, which we saw that the CSF became clear and there was a multiple T cells, the whole cells were T cells. There were no B cells in the flow cytometry of CSF. But after about 4 months, he started to have appearance of a B clone. So the CNS disease still very difficult with the CAR. Marrow diseases seem to be better.
Dr. Rajat Bhattacharya, you want to add anything?
Sir,
audio is a problem. Okay. Dr. Rahul.
And
yeah, no, we couldn't hear you. Let's try. Can we hear you now, Rajat?
Okay.
No, audio is a problem.
Can you hear me now?
We can hear you now, yes. No,
Yeah. Can you hear me now?
Yes, now, yes.
Yeah, you can hear me. Yeah. So my previous hospital in Singapore used 19 and then 1922. But the NUH has been using 19 and co-infusion of 19 and 22 cars. So and they have a much bigger experience. And they were doing these things which Padmaja said, collect the T cells in high-risk leukemias and then keep it frozen and then produce it if necessary. And they're in the high-risk patients. So yes, relapse was still the problem, even after with our tandem 1922 CAR, relapse was a problem. But there was a segment of children who cured and with less toxicity and a long-term cure. And some of those we actually then proceeded to a transplant because they're KMT2A or they had high-risk features. So I think looking at all the Inspired Symposium, they have come up with guidelines and the Cassiopeia trial that is happening in children. I think the effort is now bringing it forward to the high-risk and probably avoiding a TBI-based transplant to at least 50% children. That's what I think is going to happen. So in Calcutta, I haven't done because it's not approved till less than 15. But yes, it's happening.
Thank you. Rahul, very briefly, do you want to say something from Mumbai? Rahul Purwar?
Sure. So less than 15-year-old, 3 to 15, we have done around 12 patients in pediatric, and many of them are doing well, even more than 2 years now, a few of them. And beyond 15-year-old, we also have done around 6 or 7 in the trial, but now around 50 patients in the off trial during this commercial phase. So we see very good data, but of course, relapse is a problem. So in our trial data, we saw 50% patient have PFS around 10 or 11 months now. So that's the data as of now. I think once it matures, hopefully it will look even better.
And now you are making product for multiple centers in India?
Yes, so now it is available for across the country for 15 years or older for ALL as well as for the lymphomas.
Thank you. Dr. Verma, your question. Dr. S.P. Verma.
Yes. So very nice talk. Both of the talks were very nice. I just wanted to know, like, how long after CAR T infusion you suspect, CRS as the possibility of fever? Is it a time point like after which you consider it more due to infections rather than CRS?
So Vikram and then Padmaja.
Yeah, so, from the literature, usually it is early. Usually you don't see it late. It usually happens in the first 3 to 4 weeks. But Padmaja was talking about one she saw after a few months. I have not seen it till today, coming after 3 weeks. Most of them that we managed, or at least we didn't call it CRS. I hope we didn't miss any. It's unlikely. They are well. So usually, I would say it's within the first 3, 4 weeks. It can happen very fast sometimes when in some patients, and sometimes it can get a little bit delayed. By 6th, 7th day also it can start. But I'll be honest with you, beyond usually we discharge around 2 to 3 weeks, and when people come back with fever, that's not the first thing on my mind. Is not a CRS when it comes beyond 3, 4 weeks.
Thank you, sir. And
Yes, your response, Padmaja.
Yeah, absolutely. The first 2 weeks, but very niggly fevers, not patient otherwise well. That's what we're talking about. Probably there is a CAR reactivity going on, but not significant enough for you to act on it. And we did.
So is there any requirement for ferritin and IL-6 to be monitored even after a specific time period?
They were not that high, unless the patient had got a very significant high-grade fevers, grade CRS3, like haplotransplant, the way you get the CRS, that's the time, even if in them you do IL-6, you would get more than 1,000. But here in our patients, we didn't get that high numbers.
And is availability of anakinra must for the facility doing this CAR T treatment?
It's not, but I think I've not used it yet. But I think it's available easily. The rheumatologists use it all the time, so it's not a problem getting it. That's available in the hospital, sure, I know, but I've never used it. So.
The rheumatologist who can give you from where they get it.
So routinely they're not using, sir, but we have to ask for the availability, and I think it's very costly also compared to tocilizumab.
Check that again. Yeah, I think it's not that expensive. I mean, just check it again, because it's available in the hospital. Yeah. No, in the context of CAR T cell, 1 lakh
it's
is
not
not
expensive. Relative, isn't it? Yeah.
Okay, we move to the next question from audience. Oligo or polyclonal IgG bands do come after auto transplant, and they suggest good prognosis. Does something like this happen after CAR T?
I don't have the answers for that. Not read it.
No, we're almost depleting the B cells completely. Where is the production of even the globule? Yeah.
Okay. Akhil, you want to mention something about manufacturing?
Yes. First of all, I wish to thank Dr. Mohan, Dr. Vikram and Dr. Padmaja for a beautiful lecture. I think it was very, very eye-opening. So regarding manufacturing, what Dr. Padmaja said is absolutely correct. That when you look at the literature in myeloma, you see a lot more manufacturing challenges than in leukemias and lymphomas. And when we talk to our colleagues in the US, one of the reasons they have conveyed to us is that in myeloma, these are much, much heavily pretreated patients. If you look at the median lines of therapies in myeloma, it's almost 6 or 7. In our own trial, the average median line of therapies is 6. When you compare that with BALL or DLBCL, you're really talking about 2 to 4 previous lines of therapy. So these are more heavily pretreated patients. So what happens is their cells are more fragile. So we are going to have these fragile cells. So that thing is not going to disappear just because of this challenge, if this hypothesis is true. Now, when you look at the literature does suggest that at this time there are failure rates in the range of anywhere from 15% to 25% with BCMA, as opposed to 5 to 7% for CD19. However, out of the literature, what our colleagues in the US are telling us is that they believe that the manufacturing optimization can reduce these challenges a lot. In fact, I had a call with Dr. Padmaja and I conveyed to her that, our team is very, very confident because we had some preserved, cells from the patient, which we did some R&D, and we are very confident that the patient, whatever cells patient has, they are probably okay. So we want to do manufacturing of that patient again once we are able to optimize the process. So in fact, if of the literature, what people in the US are telling us that the actual manufacturing challenge in BCMA is reducing down to less than 10%, while the literature says 20%. Of literature, it's down to less than 10%. So they are already optimizing. And what they are saying that, yes, we can blame the patient cells, but let's not do that. Patient cells are always going to be fragile. Let's try to find a way. Let's try to optimize the manufacturing process in which we can still help those patients. So our scientists, with the help of our US colleagues, they're very confident that we would be able to make this much more broader. What we have to realize is that we did this technology from a technology transfer from China. And right now we are using that technology. But we will optimize that process in the next 3 months. We are confident that we would improve that markedly. So once we are in the commercial setting, we think that our manufacturing success would be the same range as CD19 and in the same current range as BCMA, which is not reported in the literature yet.
Thank you. Thank you. Jeevan, your question.
Thank you, sir. Thank you, Dr. Vikram and Dr. Padmaji for organizing this wonderful seminar. So I have want to discuss one of very refractory patient of myeloma. It is around 45-year-old male. He initially received VRD. After 4 cycles of VRD, underwent autologous transplant. During autologous transplant, we were able to mobilize a very good number of CD34 cells. So half of the product we have cryopreserved. Rest half we have given and patient underwent autologous transplant. But after 1 year of autologous transplant, he was on botulinum maintenance. He relapsed. And we have given carfilzomib, pomalidomide, dexamethasone. Initially, he received PR, but again, after 6-7 months, again relapsed. Then we have given daratumumab-based treatment. After 6 months of daratumumab-based treatment, again, he has progressive disease. Then he underwent BCMA CAR in Israel. Post 2 months of BCMA CAR, he again relapsed. So now what should be the next line of treatment? Should we do some allogenic transplant? We already have his cryopreserved stem cells. Should we again try autologous? Or other option may be that we can try with GPRC5 inhibitors like talquetamab. So out of these 3 options, what should we give now?
It depends on how intensive your relapse is. If you've got a serological relapse, you can rescue and you can do a second or 2. Certainly transplant will give a little bit longer, but it's not long lasting. Meanwhile, you have to look at the options of how you're going to maintain this patient. So probably maintaining on oral medications would be good. I would certainly suggest a bromodomain inhibitors. They're doing well. AUR107 trial, if they're on. But what are your light chains? But you have got limited options. These are all like, you could say something, but yeah, that's what I would have thought.
As such, patient has no cost issues. One option which we are thinking talquetamab. other allogenic stem cell transplant. Now, at the time of relapse, the kappa light chain is around 1000. He has around 2.5 M band, and bone marrow is showing 40% plasma cells. So that kind of relapse. And this is very rapid progression. Within 6 months after any line of treatment, he relapsed. With BCMA CAR also, within 2 months, he relapsed.
You need to get him into remission before any allo transplant, isn't it? That would be one of the antibodies.
So we are thinking that if we do one autologous transplant with melphalan followed by allogenic transplant, because this patient has very refractory disease.
I don't know what Vikram says, but certainly with such amount of disease, just doing an auto, if you've got an options of bispecific or trispecific, may be easier. You can't have an auto tandem allo that may be very toxic for such amount of disease. That's my thoughts. I could leave it for Vikram to have thoughts about. Yeah.
Vikram.
Yeah, so no easy answers. I'll just tell you what, if he's a 41-year-old man, as you said, and he's very well, disease rapidly progressing. Bottom line is his prognosis is very poor. But if you really want to go all out and try therapeutic, I don't have any experience with the bispecific that you're talking about. But if you could get him into a remission with that, I would take him for an allo after that. We would take him for an allo. But if he can't achieve remission, we probably would not take him for an allo. We would like to see disease as good control as possible, preferably MRD negative, all of which may be difficult to achieve before taking for that.
And sir, should we now, we have to
The
check.
second auto, I'm not, if you're thinking in terms of allo, I would probably not do auto and then follow with an allo. We would use a DARA DCEP or something like that in case it's some response to that and get a good, because he's 41, we're talking about a 41-year-old man who's otherwise well and fit. We would try that. We would intensify.
Sir, for achieving remission, can we use autologous because we already have cryopreserved stem cells?
No, I know that. I hear you, but I'm just saying the cumulative toxicity, you already gone through one auto and you have to take him through conditioning for a transplant as well. It's all going to add up.
Okay, sir. Thank you.
All right. Few questions from the audience. Do you give TOSI in patients with persistent fever in grade 1 CRS? Padmaja?
That's what the guidelines say, that if you have more than 3 to 4 days, you could give. But if it's a low-grade fever, if patient is looking well, you could wait. But as long as you've got the drug on hand.
Vikram?
We don't give. One is you have to get the money for this. It's an expensive thing. And so that's a limiting option. But in addition to that, in our experience, we don't use it. We use it only when there's a little bit of hypertension comes on, goes to grade 2 at least, before we consider tocilizumab. Otherwise, we just stay with the steroids. And even the steroids in grade 1, we probably would defer.
The other question is, can you repeat CAR-T therapy?
You can. So the success rates has been reported in CD19. I'm not sure about the myeloma data. I know that it's been reported in patients with B-cell malignancies and shown, if I remember right, a 30% response.
Padmaja?
Yeah.
Okay.
I'm not aware of it, as Vikram said.
Good. Amit, your question. I know you are muted, I think. Yeah, now we can hear you.
So fantastic talk, Samir ma'am. Regarding this B-cell aplasia, which usually lasts from 3 months to 6 months, if there is early recovery of this B-cell aplasia, are these patients of high risk of CAR T-cell failure? And this will be subjected to alternative therapies like stem cell transplant, allogenic stem cell transplant, or bispecific, for example. Usually the B-cell...
I don't think you should take these recovery of B-cells as a failure of CAR T-cells per se. B-cell aplasia can persist even much longer. In fact, 2 of our patients now, almost 1.5 years, are still B-cell aplasia. There is a correlation with loss of CAR T-cells and recovery of B-cells. And there's some link to disease recurrence in B-cell ALL, but not so much of a correlation in lymphoma, for example. So I don't think the absence of disease, and unless you already pre-planned that it was part of the algorithm anyway to get MRD negative and bridge it to an allogeneic transplant, in which case it changes completely. But if that was not part of your baseline algorithm, I would not just take loss of B cell or B cell recovery as a parameter to make any decisions on treatment if the patient is totally asymptomatic and diseased.
Thank you, sir.
Thank you. Another CAR T specialist, we have Vipul Sheth with us from Delhi. Vipul, you have been quiet. You want to add something to whatever has happened today?
Yeah, I'll just say that at Hutch, we used to transplant everyone in CAS, so I don't know the long-term outcome of only CAS. But since Dr. Vikram, you're already there, I just want to ask you, I have two patients.
Vipul, little loudly, closer to your mic.
Hi, can you hear?
Yes.
So, Dr. Vikram, I just wanted to ask one thing. I have two patients of ALL, which I'm struggling to, first of all, put into some kind of remission. And I've been discussing with Dr. Gaurav and Rahul. We are just looking at ALC count and doing the collection. In your trial, did you look at CD3 cutoff to do harvest? And what blast percentage you accepted in peripheral blood before you do collection? So, because if you're florid blast, you are just collecting blast and you're not going to transduce them. Right?
No. So the highest, the bottom line is, in some patients, you're not going to get disease control. So we do our best to get some kind of disease control before we put them on the apheresis patient. But one of our patients had 27% blast, completely refractory to everything, including inotuzumab. And that's a patient we took up, and he had a grade 3 CRS, significant disease, you were likely to more toxicity, but he went into MRD negative by day 90. So, I mean, I would not flog chemo beyond a point. So if you want to go on the patient in good performance status, if you've done all the standard things, I would take my chances in apheresis, and I don't think there is a single cutoff that tells you that this is the point at which you should not do it. If you have more lymphocytes, it's a different thing. But others, you should apheresis him, and you should send the cells for CAR T production.
Yeah, because
that may be his best option.
At Hutch, we used to take many patients with 30% blast, and we did get good
results. We've done that. We've done that, and I can tell you we've not had a problem.
Okay.
There was a concern initially about transducing the malignant cell, etc. None of that has held out to be true. Has not held out as a problem.
And do you look at CD3? Because I've not, even at Hutch, we used to not look at. So
no, we don't look at CD3. I don't think it has any. As I said, no, there are a lot of things people do to try and predict, but I'm not sure. I mean, some of this is, it's not everything has evidence, but some of this people do, but I don't think it's based on any hard evidence to say this cutoff and that cutoff and this proliferation, that proliferation, but people do. At the end of the day, you want to avoid manufacturers' failures as much as possible because there's a lot at stake in terms of costs, implications, etc.
Okay. So the main thing in ALL is to bring them to CAS. If I can bring them to CAS, and it's a success, I will even consolidate them with transplant. But the basic problem with ALL is they don't make it up to the CAS. So as fast as I can collect it is better, right? Even if it's 27, 30%.
I think so. Yeah. If you can get to MRD negative, that would be great.
Yeah, Dr. Gaurav was giving me a cutoff of 10%. So I just thought I'll take your
10% of what?
So peripheral blood blast. Like he said he has done with those and he could collect, but you are saying 27% is good enough.
I'm just telling you my experience. What I'm saying is I don't have a cutoff. So this patient had no choices. So I'm not going to flog him anymore. He's had all the standard therapy. He's had inotuzumab. He's not responding. Beyond a point, if you flog him, he'll die. So there's no point flogging it beyond a point. When you've done everything, that's all you can do. So there's not much more that's going to be achieved by giving him any more chemotherapy.
Point is conveyed. Padmaja, you want to add anything?
Yeah, at the worst, we could fail the collection, but we should try. And just want to say, in Auto1 trial in UK, there is a patient with a 1 lakh count whom we all thought that no way we would get it, but he was able to culture and get a CAR production. So that has completely taken away the picture. So that was a 62-year-old with a high WBC, could still collect. So yeah, just wanted to share. Yeah.
Thank you. So we have no more questions in the chat box. We have no other raise hand sign. And it is 1:20 now. So on my own behalf, extremely grateful to both the speakers. On this particular day, you have taught us a lot, irrespective of whoever we are. Our knowledge of CAR T has increased many-fold today. So thank you to both the speakers. And I hand over to DRL, that is Mr. Tarun Pratap Singh, for the official vote of thanks.
Dr. Agarwal, Tarun is stuck at the airport since morning because of the technical glitch.
You go ahead.
So I will take this opportunity to thank you for providing a space for discussion on the existing cell and gene therapies and for myeloma specifically. Like everyone has mentioned, thank you very much, Dr. Matthew sir and Dr. Lokireddy ma'am, for the presentations. And thank you to all the panelists present here for their discussion and sharing insights from their clinical practice. I would also like to thank Dr. Akhil and his team. Dr. Devesh is also present here, for working on Ribricel over the past many years. And in the coming year, as we go into the phase 2, Origin, Dr. Reddy's will work hand in glove with all hemato-oncologists to improve access to this innovative therapy. Thank you once again, Dr. Agarwal. I hand it over back to you. Thank you, everyone. Thank you, Dr. Matthews, Dr. Lokireddy.
Bye-bye to everybody. Bye.
Thank you, sir. Thanks,
Bye.
everybody.
Thank you.
Thank
Bye-bye.
you.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.